Welcome everyone to today's webinar, which is on understanding dysautonomia and COVID-19. This is the first part of a two-part seminar. And today I am joined by Dr. Gharbo, who is board certified in physical medicine and rehabilitation and neuromuscular electrophysiology, and he has 24 years practicing polytrauma rehabilitation and integrative pain management. Dr. Gharbo was recently named Director of Cardiac and Wellness Integration at Virginia Commonwealth University in Richmond, Virginia. He published a synopsis of his methodology, Autonomic Rehabilitation, Adapting to Change, in the PM&R Clinics of North America journal in 2020. And in 1988, he was the Ohio State University's top male scholar athlete and the university's first walk-on All-American wrestler. So it's a pleasure to have you here today.
Well, thank you. Thank you for having me and that kind introduction for the 21st and the 20th century. Thank you.
So to get started, Ron, can you tell us a little bit more about autonomic health? What makes up the system, the autonomic nervous system, and what happens if there's a breakdown in the system?
Sure. First, I'd like to do my disclosures like any good academic talk. I would like to say that I have no financial relationship with PN Medical for this talk or otherwise. I did a few months ago develop a relationship as an advisor for Leaf Therapeutics, and I have in the past been an investor for PeerBridge Health.
Thank you.
And this is a great webinar. I did sit in on the previous one you had with Mount Sinai. Obviously, New York bore the brunt of the initial COVID epidemic, and they are leaders in the post-COVID rehabilitation process. There's several terminologies. Since it's a varied audience, I'm just going to say long COVID today. And so we don't get wording is very important. So I'll just use long COVID. And one of the papers they put out was very important. They have obviously a vast experience of cardiorespiratory rehabilitation. But one of the things they said prior to phase one, breath work is important. And that's one of the, and they also identified the other things that we know is that fatigue's a big problem, as well as the relapses in fatigue with exercise. So this is a follow-up to those important things that they published this year. At Virginia Commonwealth University, the Department of Physical Medicine and Rehabilitation, we happen to be the hub for the entire military and Veterans Administration research consortium for traumatic brain injury. And that's over 25 facilities, and it's measuring people who have had multiple concussions. And one of the long-term questions we're trying to monitor and answer is, oversimplistic, if you have, say, 3 concussions, are you destined for dementia? And we don't necessarily believe that, but that's one of the main things. And we just got a $5 million 5-year grant. And so these are people with multiple concussions and PTSD and polytrauma. And so they have some autonomic dysfunction already. And we're going to track them, control group versus people who get COVID. And we're going to track them with biomarkers. And I think the two things that we'll talk about today that it sort of pushes forward is a more objective, what we mean by starting with breath work, trying to be a little dive down into that. And then the other is instead of just imaging and inflammatory blood work, biomarkers and subjective, I'm going to talk about electrophysiological biomarkers. But your question was about the autonomic nervous system in general. And oversimplified, it's 2 levers. And I don't like the term relaxation response because we need to think of that parasympathetic system as an active. So I use an automobile analogy most of the time. So I'll talk about the throttle, the gas pedal with the right foot, and then the braking with the left foot to imply that when we, in certain breathing techniques, we are actively engaging the braking system with our left foot. So, and typically clinicians, when we talk about dysautonomia, disruption of the autonomic nervous system, we're almost always typically talking about the sympathetic system, and that manifests itself in lightheadedness, passing out, elevated blood pressure. So when you see a car run off the tracks, the first thing might seem like, well, they were going too fast, right? But it is possible their brake pads didn't work. So you don't initially know. It could be both. It could be one, or it could be the other. And so one of the big paradigm shifts is yes, people are manifesting these gas pedal symptoms, but almost all of them have dysfunction of the braking system and the health of that braking system. And that's really the purpose of my publications, my case reports, and what I'm trying to do with my new role recently here at Virginia Commonwealth University, and get the focus on this enormous wealth of data. And what's exciting is that there is decades of data, and the digital age is allowing us to crunch data. And that one of the joys I get is ultimately I'm a teacher, and I like seeing light bulbs go off when I connect the dots for people. That's one of the things I enjoy most. So getting the shift from looking at the gas pedal, why they drove off, and let's look at the braking system and the recovery system. And that's the fundamental premise of what I'm trying to do.
I really like the analogy of the car. That makes it much easier to understand the two parts of the system, really. So when we talk about dysautonomia, what are some of the causes and the consequences of it? And right. As an individual, how would I know if I was affected by dysautonomia?
So the autonomic nervous system is the two-lever interface between you and the world. And when there's dysfunction in that, it can show itself again. There's sort of sympathetic versus parasympathetic. But ultimately, when people, and so the number one post-long COVID symptom is fatigue. And if we take our, glasses off and look at things differently, there's whole bodies of literature of cancer fatigue, fatigue related to depression, fatigue related to PTSD. In the healthcare burnout literature, it's the inventory they use emotional exhaustion. One of the other components is compassion fatigue. People with autoimmune polyarthralgias, the number one complaint is pain. The second most common complaint is fatigue. And people in chronic pain have fatigue. So chronic fatigue and the National Academy, and we're seeing this dysautonomia in long COVID, and we see fatigue come as a paramount. And then we see the research dollars. So if anybody who slipped through the cracks in healthcare with their problems with POTS, which is postural orthostatic tachycardia syndrome, which is this typically young ladies initially passing out or high heart rates and inappropriate response. They're driving off the course too fast. The research dollars for them is going to be enormous because of this major problem with fatigue and disability related to long COVID. So they are going to get more attention. The specialist in autonomia, it's not a specialty. It's translational throughout the different organ systems. And in some places, it's a cardiologist. Some places, it's a rehab doc. Some places, it's a nephrologist. Frequently, it's a neurologist. People coming at it. And like me, I was in polytrauma rehabilitation. Then I started to see more and more patients with POTS. And now I'm going to have a career shift. And a major component is going to be long COVID rehabilitation. But but dysautonomia is translational and it's underneath. And so anyone who suffers from persistent sympathetic activation, it could be from external stressors, job, it could be from internal, concussion, long COVID, fibromyalgia. So it is anything where stress makes your medical disorder worse and you suffer from fatigue, almost always will be able to track some parasympathetic dysfunction. When it gets much worse, or depending on your physiology, so in POTS, I tell them that they have opossum syndrome. Their reaction to enormous fight or flight is passing out. For somebody else's, it might be anger. But based on their physiology, they pass out. So that's their gas throttle manifestation. But underneath it, I believe ubiquitously, there's parasympathetic dysfunction, and the NIH definition of dysautonomia is parasympathetic and or sympathetic dysfunction. So if I use the definition correctly, it's incredibly broad, but clinicians typically talk about anyway.
So that's really interesting that it's kind of the part of the parasympathetic nervous system is under-recognized. So if I came to a clinician with chronic fatigue due to different causes, how would the clinician assess that I have dysautonomia? What would the clinician do? What would they look at? What are clinical, physiological examinations that it could do? What tests are there? What biomarkers should the clinician be looking at?
Right. So if you just have chronic fatigue, you might have seen a whole host of specialists and given up on medicine entirely and gone outside of healthcare. And hopefully you got up with the right person who can guide you. If you perchance had some of these throttle sympathetic dysautonomia type symptoms, you'd probably get a referral. There's about 25, 26 university specialty centers that do autonomic testing. Quite frankly, it's anywhere from half a year to a year waiting. Typically, it's a giant panel of tests on assessing both levers. And then there can be quite a great variability of how comprehensive the treatments and so forth. So at VCU, I'm excited that it's not just me, but there's some other hires and things being implemented to make it really a translational process. So things are I believe, going to look very different in a few years. Mm-hmm. With remote patient monitoring as well and wearable technology that's going to help us. But right now, they've really fallen through the cracks, but there's hope. Would you,
because you talked about HRV earlier, didn't you? Would that be a good biomarker to look at?
Right. So that's my passion, this science around heart rate variability. And real quick, if someone has a heart rate of 80 and I have a heart rate of 60, inherently, both sitting here, I'm more fit than they are because I'm needing less heartbeats. But if you and I each have 60 and your heart rate varies from 50 to 70 with an average of 60, but I have an average of 60, but vary from 58 to 62, your variation is vastly larger than mine, and you are both physically and emotionally more fit than I am. So it's much more sensitive than heart rate. It ends up being this massive predictor for mortality after myocardial infarction, diabetic morbidity and mortality, diabetes, depression, PTSD. And clinicians sort of pull back when I start mentioning how translation, because something can't be that's too good to be true, right? Something that's too good to be. So here's one of the things, I'm going to say it twice. Yes, there are dozens and dozens of different reasons to have chronic fatigue. And I listed several.
Mhm.
And we don't have one measure of measuring how much fatigue. But I suggest that we may have one measure that measures our ability to recover from all those sources of fatigue. And so when I'm tracking somebody remotely and they're in therapy, and we'll go over a case, and I see that they're not recovering 3 nights in a row, I know we're heading, right? So currently we're using subjective parameters in therapy, and they're good. They work in therapy. I'm not suggesting that I can monitor from a distance the therapy session. It's much better right there with the patient and the therapist. But remotely, we can track, and the therapist could track that your numbers, we've pushed you too hard. And this has been done for a long time in the athletic world. And so I think it's a paradigm shift for healthcare to move towards something as opposed to avoiding poor health. So we're going, and I use this longitudinal nocturnal heart rate variability as this lodestar biomarker of whole health. And you better pay attention. Don't worry about one night, but you better pay attention if there are 3 nights in a row where you're not recovering. You've been so typically a healthy person, they overdo it one day. If they had a good night's sleep, well, maybe they're better the next day. Maybe it takes them 2 days if they did too much. But this is what we see. What we see in dysautonomia in long COVID, we see that 80% of people have post-exertional fatigue, and we see 85% of them have relapses. And so that's the big problem, fatigue. Mm-hmm. And we doctors, we want you on the treadmill, and we want you exercising. We know the best thing for you. And these poor POTS patients are just stuck in this situation where they're told exercise, exercise, exercise. But the second they exercise, they, number one, feel terrible. And number two, they're told to not do anything because they may pass out and fall. And we know falling is the number one lawsuit out there. So they feel like they're being judged for not exercising. It makes them feel terrible. We're not giving them any instructions, but exercise. And because we don't have anything better, we just kind of walk away and make you feel bad. And this will change that. And you'll be able to watch your deterioration and your success.
Thank you. That's because you mentioned the fatigue that we also see in COVID or PAX or long COVID, whatever you want to call it. So when we look at COVID and long COVID, what are the symptoms that identify dysautonomia? You mentioned the fatigue there. Are there, is long COVID really similar to other dysautonomias, or is it distinct from that?
Well, there's a wide variety of symptoms, but for long COVID, fatigue is the number one, and your ability to recover with this biomarker. Mm-hmm. I think that there's all kinds of stuff we have to address. Yes, but this is the template that I'm trying to that you can count on, and when you see improvements, maybe if you could throw up the slide, I could take you through this case. That a recent case I had, a young lady with dysautonomia, POTS, which I think is once you understand how to manage POTS, you'll be able to understand how to manage most anything else. And it's going to tell us a lot about managing long COVID. And she came to me at the end of April, and she had 9 months, the young lady, 9 months, where she tried 2 different medication trials. She went to a cardiologist and an autonomic specialist, had all the autonomic testing. And at this point, when I saw her, she was at home, she would get palpitations and fatigue in the mornings with any activity and even with meals. She was getting palpitations and fatigue with eating. So she had lost 10 pounds and incredibly sedentary. And when you're sedentary, you're not pressing the system, the heart, and the vessels aren't being pushed. And so this is her trend that I can monitor remotely. This is an entire night of her heartbeats tracked weekly. So since November 1st to mid-October. And you see it's quite low at night. And we started on a breathing program, breath work. Again, I think objective is better than subjective. So this is why I'm passionate about heart rate variability biofeedback. It's the breathing. It's using your diaphragm to modulate this HRV during the day. And your brain, with a habit of it, starts to pick up. So as you see that first peak a couple of weeks later, she quotes to us the first one, just off the left. Yep. Yeah. The quote in the clinic there was, finally, something that works. The one just to the right. That one. Yep. She says, finally, something that works. And I hadn't got her into PT yet. And I was actually having access problems to getting into physiotherapy. And so in retrospect, what I did was I said, try and gradually increase your physical activity on your own. And you watch it plummet. So then I tell her to go ahead and back off, and you see over several days it comes back up. And the quote when I see her telehealth on there is, finally I have some control, meaning she's starting to put the link together of her activity helping or hurting her. Now, in retrospect, so at this, I'll get back to that in a minute. Bring me back to that dip if I forget. But at this peak, she now starts physical therapy, okay? And her HRV gradually goes down, and she's potentially starting to feel terrible again. But she's making gradual advances in her function, which is essential. And at this point, I prescribe a liter of fluids, and she vaults up, feeling better. And a lot of physicians are reluctant to prescribe fluids because they see this almost joy that people get of how good they feel. Her boyfriend said, that's the best I've ever seen her, was right after that liter of fluids. And so they're reluctant because it kind of looks like the patient that got an opioid and feels too good with that. So I'm proposing something very different. So there's a lot of patients on fluids twice a week, every week, the rest of their life. What I do is I first implement the breathing, okay? I didn't implement a treadmill, resistance training, or fluids. Once, I want you to put your hope in tracking and in breathing, and we're going to use the fluids as supportive. So the order that I wrote was 1 liter of fluids once a week as needed, not scheduled twice a week, chop, 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 but as needed. So she had some comfort knowing that there was some backup, and this wasn't the long-term solution of the plan.
What do the fluids do?
So that's a long explanation, but it's intravascular volume. So they're told to have salts, they're told to drink fluids, but sometimes when you're behind the 8 ball, so to speak, in this situation, IV fluids are dramatic, and athletes will get them at a halftime of a football game, and they feel fantastic. If you ever go in viral illness into an urgent care, you'll walk out feeling a lot better. The antibiotics haven't worked yet. It's the IV fluids they gave you. And so it has quite dramatic the way you feel. So she ended up getting IV fluids 4 more times over the rest of this period since October, and is not on it now. At the end of August, you still see she's bouncing up and down. And in fact, she's independent because now I'm between jobs and I'm hiking out in the wilderness, and she's on her own, but she and her therapist are figuring it out. And so you see at the end, her numbers are better, but what's vastly more important is she's not on IV fluids. Another doctor tried to prescribe a beta blocker. I said, let's hold that off. That could be a backup if we needed it. But at the end, she's now exercising 5 times a week on her own, including jogging. And she does get palpitations at times. She does her breathing every night. And whenever she has palpitations, she's eating meals. She's put on 8 pounds. And the real key is now she has this device that she tracks her own. If she gets into trouble, she's going to reach out. I don't suspect, but it's conceivable, maybe she contracts COVID or some other illness where IV fluids could rescue her. But she can self-track, self-monitor. She's learned the skill of self-management with the nocturnal, and she's learned the skill of the breathing techniques. Both are objective and can be tracked now in this age much more easily.
So self-management is key in this.
Yes. And so getting back to that dip way back there, what I've learned since then, and the next one.
This one, next one here?
Nope, way to left, between June and May, that dip right there. So what I would do now, and one of the reasons why I'm on this webinar, is I believe respiratory muscle training would be the step between the heart rate variability focused breathing and that phase 1 cardiopulmonary, and give her a device to now strengthen her breathing without doing the other resistance training. And I think it's possible I could have avoided that dip and done a gradual breathing practice and strengthening the muscles. One of the things that's happening, so when you do the breathing practice, we know if you do it for 2 months, you will be physiologically better, even if you're not exercising. What you're doing is it's a baroreceptor exercise. These receptors right after the heart and the aorta, right? If you're not exercising, it's not doing it. But when you exercise, it's expanding and you have to contract against, and that's exercise of the aorta. So fluids affect that, but then so would creating significant pressures with a respiratory device. And so what you're doing is aortic stretching, basically. Mm-hmm. You're pressing the contractility of that aorta, and so this is the link that a lot of physicians that aren't familiar, one of the things they recognize that these people with hypermobility, these collagen vasculators, Ehlers-Danlos, so forth, why do I see so many of them? Well, it's the collagen within the aorta that makes them a little less firm or resilient. There's different terms, but that's part of the problem. So the key feature is long-term, you must have exercise. So that was one of the early things I stressed. Exercise for the rest of your life is mandatory. But how will we get you there? And that's going to be a rocky road. And this is a rocky road. But your aorta needs its stretching, and exercise will do it. But let's first do the diaphragm breathing with heart rate variability biofeedback. Now let's start working on the respiratory strengthening. Now we're going to start doing phase 1, 2, and 3 of rehab program.
You're stressing the importance of breathing here. So how do you start them? What is the breathing reset that you talk about? And when is the right time to introduce strengthening? How do you know it's the right time to start on a strengthening device?
Right. I want it to be as simple as the way a physician would write it is resonant breathing, 10 minutes, BID and PRN. Okay. BID means twice a day. PRN means as needed.
Okay.
Ideally, I want them to do the breathing, I say after technology and before you go to bed, and one other time during the day. But why I say that is if you do it just before bed, you're cueing the brain to go into recovery mode. I'm going to engage the brake. Oh, they're doing this every night. This is the time where we start producing growth hormones, healing hormones. This is the time we start sending out the signal. And you get a jump on that signal. You're cueing the brain, you're teaching the body, oh, okay, we're putting down this nasty texting or this nasty political show. And now I'm going to do the breathing and it's time to recover. So I talk about this longitudinal nocturnal HRV. The skill is becoming intentional and independent with your own recovery. And you can and track it. But so the breathing will trigger it. And so, at that visit, when her numbers were going upward and she's feeling a little bit better, she can handle the next challenge. And instead of me saying, do it on your own, because I couldn't get her with a therapist right away, I think that would be the moment if they can't handle it. Now, some people, people are, it's based on function. So it's not a certain number of days. It's, it's, I believe everybody needs to learn the skill. And if they can't tolerate the resistance training and supine that progresses to sitting and standing and so forth, if they can't progress that. So if they learn the skill and they can't handle, and they're in that spot, I think respiratory muscle training is the next natural step in that rehabilitation process.
But you have to have mastered the breathing first.
That's my opinion. And I believe heart rate variability biofeedback is the most studied breathing technique and has decades of data. In fact, this is not new. It's just been ignored. I have colleagues that have published in 2004 saying that heart rate variability biofeedback should be part of every cardiopulmonary rehab program. But we haven't. But long COVID has put that front and center.
So what we're looking at here, that was a POTS patient, you said. Would your parasympathetic rehabilitation program for a COVID patient would be very similar to this one?
So one of the, we need models of treatment. So people with long COVID, they might be in their 40s, have diabetes, XYZ. So it gets vastly more complicated. So this is why POTS will get a tremendous amount of research dollars, because they're typically otherwise, such as her, prior to socialized isolation, there's a perfectly healthy, high-achieving 18-year-old. And so now you have a discrete way of understanding dysautonomia without all the other comorbidities. So we can learn from that. But yes, long COVID is going to be far more complex than what I just. So if someone's listening to this and criticizing, well, yeah, they're absolutely correct. I'm going to present my best case, but it's a template, and really at the end of the day, there's standard cardiac rehab, and I'm saying start with breathing, which is what other people are saying. I'm just saying start with the most objective, and then after that, I'm saying do respiratory muscle breathing, and those are the kinds of things that I think we're going to see evolve over the next few years, and with a tremendous amount of remote patient monitoring in a world of social isolation and access problems.
So, question that everybody's asking, that everybody wants to know, and we spoke to some patients or people before that are affected by POTS, by dysautonomia with different etiologies. Does it work? Do you get better? What's the goal? How long does the treatment take? What's the success rate? Could you just comment on that?
Yeah. So that is incredibly difficult. So again, she was sedentary for only 9 months. Mm-hmm. There's a lot of people out there that have been in this vicious circle for a decade, and they have diabetes, and they have so there's absolutely no predicting. However, what I would say is we need a method, and having a method is hopeful. And so I believe this method of tracking fatigue and your ability to recover fatigue and have a process can provide hope for a process. I don't believe it's the device that I'm working on. I don't believe it's the device you're working on. I believe it's a process that includes multiple mm-hmm. devices that is hopeful itself. And so so I make a huge point of it. It's not the IV fluids, right? You're going to prescribe it twice a week for the rest of your life and see you later. It will stop working eventually if you don't learn anything from it. So I believe there's two things you have to learn. You have to learn this conundrum between exercise making you healthy and making you more fatigued, and devices can do that. And then you have to learn how to breathe properly. And after you learn how to breathe properly, with proper diaphragmatic techniques, with heart rate variability biofeedback, then strengthening, and then the next typical physiotherapy tools.
It does really sound like a paradigm shift from going to the physician, expecting a quick fix, a medication, a pill, whatever. We have to start working on a process that ends up in a management and getting back to functional. Are we talking complete recovery or getting back to functioning?
So I always say people all have different chinks in their armor. So I had an arrhythmia 20 years ago. And so I had an irregular heart rate. So I technically didn't even have an HRV. My heart rhythm was so bad. Now, for my age, I'm in the 98th percentile. But I always have that chink in my armor. So this young lady, if she gets ill or burns the candle at both ends for too long, it will show itself. So you're never cured. If your mm-hmm. thing is migraines and you have a threshold and you live your entire life here, you pop over all the time. But if we gradually get you away from your threshold, now, if you're an accountant and you're getting migraines during tax season, well, now that makes sense. Whereas before, you're just getting migraines all the time, and you're trying to think, why am I getting migraines? Well, it's because you're living right under your threshold, and that's the problem. We got to get you more and more reserved, and so the breathing, the exercise, and the proper rest gets you more. So she has now that she's actually vastly more resilience. If she were to get infected, she'd have vastly less problem. But no, if she decides to take on a job and forget about exercise and forget about self-care, absolutely, it's going to come raging back.
This sounds like it's, all in all, really good news for people who are affected and also for clinicians who are trying to help their patients. If people who are affected, clinicians want to find out more about what you do, what your rehabilitation program is, where can they find out more about your work and what you do?
Right. So yeah, I published the synopsis. The real key is connecting the dots. I'm speaking for a national convention and on remote patient monitoring, and there's more and more remote patient monitoring codes. So this is going to be more and more incorporated, but one of my ideals is to try and make this user-friendly for the primary care office, for the physical therapy office, and that's what we're working towards here at Virginia Commonwealth University and with my work with Leaf Therapeutics. And You guys. Thank you.
Well, thank you so much, Ron. That was really exciting. I've learned lots, and I think anybody who listened will have learned many new things as well. So thank you so much for being here with me and answering all those questions.
It's been a pleasure. Thank you.
All right, we're going to take those questions that we didn't get to throughout. We tried to ask a few throughout, but answer a few. But we do have some good ones in the chat. So Dr. Balsic, take it away.
Yeah, thank you. Thank you everyone who has listened through the whole webinar. I found this really exciting. I hope you did too. We got loads of good questions. Sorry, I have to put my glasses on to actually read them. So Dr. Gharbo, for a start, there were many questions on the breathing techniques. That you were talking about the breathing reset. How exactly is this done? Tell us more about this. Do you do this with strengthening, without strengthening? What exactly are the techniques?
So all your therapists that have a history with mindfulness and meditation, they recognize how powerful that can be in an experience with the diaphragm. So diaphragmatic breathing, good technique with that is essential. If you think of your diaphragm as a secondary pump to the heart, you can make the heart diaphragm system more efficient by diaphragmatic breathing techniques. So it's critical to have good technique with that, number one. Number two, you can strengthen the diaphragm with exercise. Number three, you can calm the mind with meditation. But then with heart rate variability biofeedback, you can take that skill. I like to use athletic terms sometimes. You can go from a college breathing skill to a professional breathing skill, right? Now you're actually getting the physiological response. And then the other thing you can do with it is you can prescribe homework, which is really powerful for a physician or a therapist to prescribe heart rate variability biofeedback. And you can see their practice, and then you can have a natural conversation about their involvement during some sort of stressful event, whether they had trouble or success. So think of heart rate variability biofeedback as surfing. You are, exercise is like this brute muscle guy who gets on a surfboard and tries to out muscle the wave. Well, exercise is great. You need to be a certain amount of strength to surf, but what you really need is the skill of synchronizing the two. And that's what heart rate variability biofeedback, and it has to be diaphragmatic. And then you can add other little techniques like, so the thing you can always take with you is 5 seconds in, 5 seconds out will get you in resonance. Okay, so that's the most studied, the most basic. And then there are next level where you can extend the exhale, where you can purse your lips and create a back pressure to keep the alveoli open longer. And so then there are several other little skills beyond that. And now that you've developed this coordination, but you've been decimated by this medical problem, now you have the ability to strengthen the muscles with, say, the strengthening device that you're available. And then you can then tolerate, and for POTS, there's a Dallas technique where it goes progressively from supine to sitting to standing exercise. And so that's what I believe the order is, and what heart rate variability biofeedback, it allows for homework, it allows for checking for homework. I think meditation and diaphragmatic breathing are incredibly important, but now let's put a structured template. This pandemic is forcing us to solve some of these problems that have fallen through the cracks. And so I hope that helps to answer the question.
Real quick before we go on, we have a lot of questions, but real quick, because there's several on research. Where would you tell people to turn to find the latest research, somewhere where they can go for more, and then we'll answer some more.
Right. So the Academy of Physical Medicine Rehabilitation, my specialty, we are taking the forefront, and they'll be publishing a series of consensus statements. So I would recommend you try and find the AAPM&R consensus statement, and I can get that to you. And the first one is about the primary symptom of long COVID being fatigue, but there will be other ones coming out, and there'll be consensus statements. So that's probably the best one, but it's just a start. The things I've talked about aren't in it.
Right.
That's AAPNMR.
AA, physical medicine and rehabilitation, PM and R.
Okay, I'll put this in the chat. Thank you very much for that. There were also a few questions. Let's stay on the technical side. There were a few questions on the fluids. So Mary Matsuri asked whether you should take them at a specific time of the day. Do you take them early in the morning? Do they take them before bedtime? And I think it was Susan who asked, what fluids are they? What's the composition of those fluids?
Yeah, you can find those recommendations. They vary a bit, and it varies from person to person how successful they are. And it's hard for me to always tell, but there's no doubt you need volume expansion. So these people with hypermobility, you can think of it, they have squishy vessels. And it's difficult for some of them to keep up. I mean, this lady I presented, this young lady, she got palpitations and fatigue just with meals. So we tell them to keep up with fluids, a liter a day, and salt to create the volume. But I never quite know. So it's hard for me to make too hard of recommendations because you never quite know how much they're really doing. And there are multiple variables, but there are standard recommendations out there for that. But I can't say that doing that before bed, that I've seen that do much significant. I know in an older gentleman that may have urinary retention problems and frequency at night, taking too many fluids at night, then you have another problem. So unfortunately, I'm not giving you a good answer on that. But when they're desperate, I think a liter of IV fluids can get them back in the ballgame.
Well, I think the overall message that we're getting is that it's a lot on patient intuition, and the patients really have to know how they feel and find out what's good for them and when. Rather than being a very specific prescription.
Clinicians can help facilitate that and help teach that. And I loved your case study because that really, it showed the whole story, what happened.
So if you take the case study, which was a POTS patient, and we talked about COVID quite a bit now, but the question came up again, is that really very similar to POTS? Can POTS be a symptom of long COVID as well? I've been,
yes,
I've heard about this in another webinar.
Yeah, I can talk to that. So we're seeing a lot of sympathetic dysautonomia with long COVID, okay? And I use POTS today as an example because a lot of them are young women without a half dozen other medical problems. So it's a cleaner example. So POTS is a way to study the dysautonomia portion of long COVID is why this is pertinent to long COVID. They both have fatigue. They both have parasympathetic dysautonomia. They both have sympathetic. What the definition for chronic fatigue is some form of fatigue and then either mild cognitive impairment or dysautonomia. It's an interesting National Academy definition. And we see this nexus after viral infections. We see it after so many disorders. And what is that issue between this fibrofog, and the fatigue? And And part of it is the glymphatic clearance of toxins, the overwhelming toxins that happen after a COVID infection. And the way to flush the brain is with long diaphragmatic excursions at night that flush the brain with cerebrospinal fluid. But you may not have full drainage, and so toxins build up, which can be various things that lead to Alzheimer's and Parkinson's and things like that. So long COVID is creating research that will help post-concussive syndrome, that we have to solve this mild cognitive impairment with fatigue. And then, pain is I would say a secondary consequence. That I would say not everybody with fatigue has pain, but I'm willing to bet most everybody with chronic pain probably has fatigue. And so I hope that answers that question.
Yeah, I think that was a good question. I think we should wrap this up probably as a last question. You've kind of described a very good pathway how you could tackle dysautonomia and long COVID being a dysautonomia. So as a patient, as a long COVID patient, how do I get my physician to support this? Where do I start? What do I do?
Yeah, I think at this point, major centers are having long COVID clinics. So your best bet is that. If you are adept and have some resources on your own, I would get a device, a wearable device, ring or wrist, and find your nocturnal HRV weekly and monthly. Don't get too wrapped up in their recovery scores and this and that. Look for that HRV and look for that image that I showed where you're tracking it over weeks. So it's your whole night, whether it's 3 hours or 7 hours, they look at the whole night. And if even if it's only 3 hours, if you've lost the ability to recover, you can't recover in those 3 hours. So there's a period of time where she's doing poorly, and before I give her the IV fluids, and she's sleeping 6 and 7 and 8 hours of sleep, but she lost the ability to recover. So she was still exhausted, even though she was getting. So one of the things it's showing is quality of recovery, quality of sleep, as opposed to just numbers of hours of sleep. So try and find that, and then also look for heart rate variability biofeedback devices. And when you turn, say, the device from red to green, you're becoming more parasympathetic. And so right now it's a mess, and you might have to get 2 different devices, unfortunately, but for now. But fortunately, eventually it'll all be wrapped up into one. And then if you want to learn how to strengthen your respiratory muscles, well, maybe Nina might have a device that she thinks might work well.
Well, there was a question about what devices you could use. There are different devices out there. I'm just typing a question here. We are not associated with any of them. We have used the BioStrap in studies. That's a wearable device you can wear on the wrist. We have used the Aura Ring. That's what I'm currently wearing in clinical studies. That gives you, both of them give you average nocturnal heart rate variability, and they give you on the app a really nice trend line so that you can really follow it over weeks. But there are other devices out there as well that will work very well. Yeah, and I think with that, we leave this. Thank you so much again, Dr. Gharbo, for this webinar. I think everybody interested in this topic was really, really excited to hear all about it. Thank you to everybody who has been listening. It was fantastic to have you all here. Thank you for all the questions.